Hello from wherever you're tuning in, and welcome back to school. I'm sure that this is the first lecture you are hearing on your way back to your junior year. And so let's start out by discussing parenteral therapies before our skills lab. So parenteral therapies refers to the administration of fluids, medications, blood products, and nutrition by routes other than the GI tract. And in nursing practice, this most commonly means IV therapy, but it also includes central venous access devices, blood transfusions, and parenteral nutrition. Parenteral therapy is one of the most frequently performed interventions in acute care settings, and as nurses, we're responsible not only for administering these therapies safely, but also assessing vascular access devices, monitoring patients for complications, preventing infection, and recognizing when something is not progressing as expected. And throughout this lecture, we'll focus on the foundational knowledge you'll need in clinical practice, for skills lab, and also the NCLEX. And we'll discuss the different types of vascular access devices, when each is appropriate, the different categories of IV fluids, safe administration practices, common complications, catheter-associated bloodstream infections, and the nursing interventions required for each. So before we get started, let's review what you'll be expected to know by the end of today's lecture. First, you'll learn the basic principles of initiating, maintaining, and discontinuing IV therapy, including safe nursing practices throughout the process. Next, we're going to discuss the most common complications associated with IV therapy, such as infiltration, extravasation, phlebitis, infection, and fluid overload, along with the appropriate nursing interventions for each. We'll also compare the different types of vascular access devices, including peripheral IVs, midlines, and central venous access devices, focusing on when each is used and how nurses care for them. We'll also review the importance of ongoing assessment and monitoring, including evaluating the IV site, the infusion, and the patient's overall response to therapy. So here's a quick overview of what we'll be covering today. We'll start with an intro to IV therapy, including what parenteral therapy is, why it's used, and the nurse's role in providing safe care. Next, we're going to discuss the different types of IV access, including peripheral IVs, midlines, and central venous access devices, and when each is most appropriate. Then we're going to review the major categories of IV solutions, isotonic, hypotonic, and hypertonic fluids, and we'll discuss when each is commonly used. After that, we'll focus on nursing management, including assessing IV sites, monitoring infusions, maintaining catheter patency, preventing infection, and safely discontinuing IV therapy. And finally, we'll finish with complications of IV therapy, learning how to recognize problems like infiltration, extravasation, phlebitis, infection, and fluid overload early, so we can intervene quickly and keep our patients safe. So before we talk about how to manage IV therapy, let's first discuss why we use it. So IV therapy provides direct access to the bloodstream, allowing fluids and medications to work very quickly and predictably. It's commonly used when patients can't take medications or fluids by mouth and need rapid treatment or require therapies that aren't absorbed well through the GI tract. And some of the most common indications include fluids to treat dehydration, maintain hydration, or restore circulating volume. Medications such as antibiotics, pain medications, or emergency drugs that need a rapid effect. Sometimes blood products, including packed red blood cells, plasma, or platelets to treat blood loss or certain blood disorders. Nutrition such as total parenteral nutrition, also known as TPN, for patients who cannot safely use their GI tract. Electrolytes like potassium or magnesium when replacement is needed quickly or oral administration isn't appropriate. So there's several advantages to IV therapy. It has rapid onset of action, it allows for precise control of medication and fluid administration, it bypasses the GI tract, and it is essential in emergency situations. However, there's also disadvantages. IV therapy is invasive, so it carries risks such as infection, infiltration, phlebitis, and fluid overload. And so it requires ongoing nursing assessment and monitoring to ensure patient safety. So, as nurses, one of the most important responsibilities is recognizing when IV therapy is indicated, selecting the appropriate vascular access device, and monitoring our patients closely to prevent any complications. Before we discuss IV access devices, it's important to review some basic venous anatomy because understanding the veins helps us choose the safest and most appropriate site for IV insertion. So when placing a peripheral IV, we primarily use superficial veins. These veins are really close to the surface of the skin. They're easier to see and palpate and are less likely to be associated with major arteries or nerves. So the veins you'll hear most often are the cephalic vein, basilic vein, and median cubital vein. The cephalic vein is located along the thumb side of the forearm. It's often a great first choice because it's relatively stable and easy to access. The basilic vein on the pinky side is usually larger, but it lies closer to the nerves and arteries, so extra caution is needed. And the median cubital vein in the antecubital fossa, it's commonly used for blood draws and emergency IV access, but because it's located over a joint, it's not ideal for long-term infusion since the catheter can easily become dislodged. And then we have deep veins such as the subclavian, internal jugular, axillary, and femoral veins. These are not used for routine peripheral IVs. Instead, they're accessed when placing central venous access devices, which we'll discuss later in the lecture. So when selecting a vein, nurses should choose one that is straight, soft, well filled with blood, and appropriately sized for the prescribed therapy. It's generally best to start distally, such as on the hand or lower forearm, and move proximally only if needed. This is going to preserve future IV access options if another attempt becomes necessary. There's also veins we should avoid whenever possible. We want to avoid areas of infection, inflammation, bruising, edema, burns, or previous infiltration. We also avoid veins in an extremity affected by a dialysis fistula or graft, the site of a mastectomy with lymph node dissection, if possible, due to lymphedema risk, and extremities with significant vascular compromise. Lower extremity veins are generally avoided in adults because they carry a higher risk of thrombosis and infection unless there is no other option. Remember that choosing the right vein isn't just about finding one that's visible. It's really about selecting the site that will safely support the prescribed therapy while minimizing complications and preserving the patient's future vascular access. One of the first decisions nurses are going to make might be determining which vascular access device is most appropriate for their patient's therapy, along with collaboration with healthcare providers. There isn't a one-size-fits-all option. The choice really depends on several important factors. The first consideration is the expected length of therapy. So if a patient only needs IV access for a few days, a peripheral IV is usually appropriate. However, if therapy is expected to continue for several weeks or even months, then a midline, PICC line, or another central venous access device may be a better option, and that's to reduce repeated needle sticks and preserve the patient's veins. Next, we want to think about the type of medication that's being administered. Some medications are really irritating, or also known as vesicants, meaning they can cause significant tissue damage if they leak outside of the vein. And these medications are generally administered through a central line because the larger veins rapidly dilute the medication. We'll also need to consider the osmolarity of the solution. So hyperosmolar solutions such as TPN or some concentrated electrolyte solutions can really irritate peripheral veins and often require central venous access. Another important factor is the pH of the medication or solution. So fluids that are highly acidic or highly alkaline, they increase the risk of vein irritation and phlebitis, making central access the safer option. We also assess patient-specific factors such as age, mobility, diagnosis, history of difficult IV access, kidney disease, previous mastectomy, or the need to preserve veins for future dialysis access. Finally, always evaluate vein quality. Look for veins that are healthy, well-filled, and appropriate for the catheter size. So patients with fragile, scarred, or frequently accessed veins may require a different vascular access device than someone with healthy veins. And remember this guiding principle. You want to use the least invasive device that can safely deliver the prescribed therapy for the entire duration of the treatment. This minimizes complications while preserving the patient's vascular access for the future. And as we move through today's lecture, you'll see how these factors help us determine whether a patient needs a peripheral IV, a midline, or a central venous access device. So now let's talk about one of the most common decisions you'll make as a nurse, which is choosing the correct IV catheter gauge. One thing students often find confusing is that the smaller the gauge number, the larger the catheter diameter. So a 14 gauge catheter is much larger than a 24 gauge catheter. Larger catheters allow fluids to flow much more quickly. So starting on the left, we have in orange the 14 gauge. This is the largest catheter size commonly used. It's typically reserved for major trauma, rapid fluid resuscitation, or massive blood transfusions where large volumes need to be infused very quickly. Then next to that is the 16 gauge, also a large bore catheter. It's commonly used for trauma patients, surgery, rapid fluid administration, and blood transfusions. And then we have the 18 gauge in green. It's common in hospitalized adults. It's appropriate for routine IV fluids, medications, blood products, and many surgical patients. If a patient may need blood, an 18 gauge is often preferred. Then we have in pink the 20 gauge is probably the catheter you'll insert most during probably a med-surg rotation or possibly preceptorship. Even when you graduate and become a new grad, you'll definitely see a 20 gauge needle. So this is considered the workhorse of peripheral IVs because it's suitable for most IV medications, maintenance fluids, contrast dye for many CT scans, and in many situations, blood transfusions as well. Then we have the 22 gauge in blue. This is used for patients with smaller or more fragile veins, such as many older adults. It's appropriate for routine fluids and most medications, although it may not be ideal when rapid fluid administration is needed. And then lastly, we have the 24 gauge in yellow. This is the smallest catheter shown here. It's typically used for pediatric patients, older adults with very fragile veins, or patients with very limited venous access. And because it's small, infusion rates are much slower. A helpful NCLEX tip here is to remember the larger the catheter, the faster the flow. But we know that bigger isn't always better. We want to choose the smallest catheter that will safely deliver the prescribed therapy. So using any unnecessarily large catheter can increase patient discomfort and the risk of vein irritation. So while choosing one that's too small may not meet the patient's treatment needs. So balancing the therapy being prescribed with the patient's vein quality to select the most appropriate catheter is going to be important. Now let's look at the midline catheter, which falls somewhere between a standard peripheral IV and a central venous access device. So a midline is still considered a peripheral catheter, even though it's much longer than a typical peripheral IV. It's inserted into a vein in the upper arm, usually the basilic, cephalic, or brachial vein, but unlike a PICC line, the catheter tip ends in the axillary vein. It doesn't reach the superior vena cava, so it is not a central line. So that's an important NCLEX distinction. Midlines are typically used when a patient needs IV therapy for about 1 to 4 weeks, especially when repeated peripheral IV insertions would be really difficult or uncomfortable. So when is a midline appropriate? We want to think about a patient admitted with cellulitis who may need 10 days of IV antibiotics, for example. So instead of starting a new peripheral IV every few days, a midline provides more reliable access. They're also used for IV fluids, electrolyte replacement, intermittent IV medications, and patients with difficult peripheral access. Nursing considerations. So before administering anything through a midline, you want to ask yourself, is this medication safe for peripheral administration? Because a midline is still a peripheral catheter, it cannot safely infuse medications that are vesicants, highly irritating, hyperosmolar, extremely acidic, or alkaline. So examples would be TPN, most chemotherapy agents, many vasopressors, and some highly concentrated electrolyte solutions. Those medications do require a central line where the medication is going to be rapidly diluted by high blood flow. Ongoing nursing assessment with midlines. Each time you assess a midline, perform a focused assessment. You want to inspect the insertion site for any redness, swelling, warmth, drainage, tenderness. You want to assess the arm for any edema or discomfort, and always verify that the catheter flushes easily. We want to never force a flush. Resistance may indicate that there is an occlusion or catheter problem that requires further assessment. And unlike many peripheral IVs, a midline should have a sterile transparent dressing, which nurses inspect regularly and change according to institutional policy, typically every 7 days if clean, dry, and intact, or sooner if loose or soiled. And although the infection risk is lower than a central line, infection prevention is still essential. So remember to perform hand hygiene before every access, scrub the needleless connector, so scrubbing the hub for recommended time before connecting tubing or any syringes, and maintaining a closed system whenever possible. There are some important limitations. So a midline should not be used if the patient needs therapy longer than 4 weeks or requires central venous pressure monitoring. Also, it should not be used if a patient needs frequent blood sampling, unless your institution specifically allows that, or requires medications that should be administered centrally, which makes sense. In those situations, a PICC or another central venous catheter is the safer choice. Now we're moving from peripheral access to central venous access devices, or CVADs. And unlike a peripheral IV or midline, all central venous access devices have one thing in common. The catheter tip ends in the superior vena cava, just above the right atrium. So because blood flow is so rapid in the superior vena cava, these devices can safely deliver medications and solutions that would severely irritate or damage a peripheral vein. Some common reasons a patient needs a central line include long-term IV therapy, chemotherapy, TPN, vasopressors, hyperosmolar or vesicant medications, frequent blood draws, hemodynamic monitoring in critically ill patients. So let's look at each type. We have a non-tunneled central venous catheter. So a non-tunneled central line is the one you'll most often see in the ICU or emergency department. It's inserted directly into a large central vein, usually the internal jugular, subclavian, or femoral vein, and the tip sits again in the superior vena cava. These are intended for short-term use, generally less than 2 weeks. They're ideal when patients need multiple IV medications at once, so things like vasopressors, rapid fluid resuscitation, central venous pressure monitoring, because again, they're entering directly through the skin into a central vein. They have the highest infection risk of the central lines, so they're removed as soon as they're no longer needed. Then we have a peripherally inserted central catheter, or a PICC. So although it's inserted through a vein in the upper arm, the catheter travels all the way until the tip reaches the superior vena cava. And we want to think about it as it's inserted peripherally, but it ends centrally. PICC lines are excellent for patients needing therapy for weeks to several months, such as long course of IV antibiotics, chemotherapy, TPN, frequent blood sampling. Many PICCs are inserted at the bedside by specifically trained vascular access nurses using an ultrasound for guidance. And patients can usually go home with a PICC, so nurses spend a lot of time teaching patients how to care for that. Then we have tunneled catheters. These are designed for long-term therapy, often months to even years. And unlike the previous devices, part of the catheter travels underneath the skin before entering the vein. And that tunnel and a small cuff under the skin helps anchor the catheter and decreases infection risk. These are commonly used, again, for long-term antibiotics, sometimes dialysis, chemotherapy, and because they're surgically placed, they're intended for patients with ongoing vascular access needs. Finally, we have the implanted port, sometimes called a portacath. This is completely implanted underneath the skin, so nothing is visible externally when it's not being accessed. And to use the port, the nurse inserts a special non-coring Huber needle through the skin into the port reservoir. Ports are ideal for patients who need intermittent therapy over months or years, such as chemotherapy, recurrent blood transfusions, long-term biologic therapy. And when they're not in use, patients can shower, swim, and perform normal daily activities because everything is beneath the skin. So regardless of which central line you're caring for, your nursing responsibilities are going to be very similar. So before using the line, we want to verify the tip placement has been confirmed, usually by chest x-ray after insertion for most new central lines. We want to assess the insertion site for redness, swelling, drainage, tenderness, or bleeding. We want to confirm that the dressing is clean, dry, and intact. And whenever accessing the line, we want to perform meticulous hand hygiene. We want to scrub the hub with the appropriate antiseptic before every access, maintain strict aseptic technique, flush according to institutional policy to maintain catheter patency. Again, never force a flush if there is resistance. Many central lines also have multiple lumens, and each lumen functions like it's its own IV. Certain medications should never be infused together because they're incompatible, so we always want to verify medication compatibility before sharing a lumen. And then flushing and syringe selection. Another important safety consideration is the size of the syringe used to flush a central line. You'll often hear the rule, never use a syringe smaller than 10 milliliters to flush a central venous access device. The reason isn't because we always flush with 10 mLs of saline, it's because anything smaller generates much higher pressure. So a 3 milliliter or a 5 milliliter syringe can create enough pressure to actually rupture or damage the catheter, even if you're applying the same amount of force with your hand. So a 10 milliliter syringe has a larger barrel, which produces lower pressure and is much safer for the catheter. Another important point here is we never want to force a flush. If you meet resistance, we want to stop immediately. Forcing saline into an occluded catheter could damage the line or even dislodge a clot, and remember where this is going. So instead, we want to assess the catheter, check for clamps or kinks, reposition the patient if appropriate. Sometimes raising the arm is helpful, and following your institutional policy for restoring catheter patency. Patient assessment, we want to always monitor our patients, not just the catheter, so assessing for fever, chills, redness or drainage, pain at the insertion site, swelling of the neck, chest, or arm, difficulty flushing, inability to obtain blood return when expected. That's another thing we want to get is blood return when we're flushing. So if we see any of that, it may indicate infection, thrombosis, occlusion, or the catheter has migrated. One common complication that every nursing student should know is eclampsia, or a central line associated bloodstream infection. Because central lines provide direct access to the bloodstream, preventing infection is one of the nurse's highest priorities when you have a patient with a PICC line or a central venous access device. Other complications that we'll go over include thrombosis, catheter occlusion, pneumothorax during insertion, especially with subclavian or internal jugular lines, catheter malposition or migration, air embolism if the catheter becomes disconnected or left open. So this table kind of just summarizes the key differences between the vascular access devices that we've just discussed. And as you can see, the biggest factors to consider here are how long the therapy is going to last, where the catheter tip ends, and what will be infused through it. So starting with the left, a peripheral IV used for short-term therapy, typically a few days. I've seen it for a week, really ends in the peripheral vein. We also have a midline. This is still a peripheral device, but it's longer. It's more appropriate for therapies lasting 1 to 4 weeks. Remember that the tip ends in the axillary vein, not the superior vena cava. And then the remaining devices, the non-tunneled central line, PICC, tunneled catheter, and implanted port, they're all central venous access devices, meaning that their tips terminate in the superior vena cava. Another important difference is, again, how long the IV or access device is going to stay in. So peripheral IV, hours to 3 to 5 days, midline, 1 to 4 weeks, PICC line, weeks to months, and then tunneled catheter and implanted port, months to years. You're also going to notice here in the chart the differences in blood draws. So most central lines can be used to obtain blood samples, although whether a PICC is used for blood draws really depends on your institution's policy. Peripheral IVs and midlines generally are not used for routine blood collection. Those valves can break pretty easily, so the pressure put on those if you're trying to get blood return might break those valves. And finally, you want to pay attention to vesicants, so medications that can cause severe tissue damage if they leak outside the vein. Those are things like chemotherapy, vasopressors, and many TPN solutions should only be administered through a central line, not a peripheral IV or a midline. The key takeaway here is always to remember what the duration of therapy we are trying to address, the medication being administered, and the patient's vascular access needs. And then we have the different types of IV fluids, and these are categorized by their tonicity, which describes the concentration of solutes in the fluid compared with the concentration of solutes in normal blood plasma. So the easiest way to understand tonicity is to ask one question, which is, which direction is the water going to be moving in? So water always moves towards the area with the higher concentration of solutes. So let's look at each category. We have isotonic fluids. An isotonic solution has approximately the same concentration of solutes as blood plasma, so there's no significant movement of water into or out of the cells. Instead, the fluid is going to remain primarily in the intravascular space, which makes it really ideal for expanding circulating blood volume. We want to think of isotonic fluids as staying in the bloodstream, and they're commonly used for things like dehydration, hypovolemia, blood loss, hypotension, and initial fluid resuscitation in shock. Two fluids that are going to come up again and again is normal saline and lactated ringer. So normal saline contains sodium and chloride in concentrations similar to plasma. It expands the vascular space without causing fluid shifts between the intracellular and extracellular compartments. Again, commonly used for fluid replacement, dehydration, hypovolemia, and the initial treatment of shock. It's also the only fluid compatible with blood transfusions. Then we have lactated ringers, also an isotonic, but it contains electrolytes such as sodium, potassium, calcium chloride, and lactate. And the lactate is metabolized by the liver into bicarb, which can help buffer metabolic acidosis. You'll commonly see LR used in settings like trauma, burns, surgical patients, and GI fluid losses. Next are hypotonic fluids. These have fewer solutes than plasma, and because the concentration outside of the cells is lower, water is going to move into the cells, which causes them to swell. So we want to think of hypotonic as water entering the cells. And these fluids are used when cells are dehydrated. So things for hypernatremia, cellular dehydration, free water replacement, However, because water leaves the bloodstream, hypotonic fluids should not be used in patients with hypotension, shock, or increased intracranial pressure. They can worsen those conditions. So we have half normal saline, which is a hypotonic fluid that you'll commonly see. It's used cautiously for hypernatremia, cellular dehydration, and then we also have D5W. So when D5W is hanging in the IV bag, it is isotonic because the dextrose contributes to its osmolarity, but once it's infused in the body can rapidly metabolize the glucose, which leaves behind free water. And so that is why D5W acts physiologically as a hypotonic solution, which allows water to move into the cells. And lastly, we have hypertonic fluids. These contain more solutes than plasma, so water moves out of the cells and into the bloodstream. We want to think about hypertonic as pulling water out of the cells because they rapidly shift fluid into the vascular space. They're used extra carefully. Some common indications include severe symptomatic hyponatremia, cerebral edema, and increased intracranial pressure. So we'll see most commonly 3% sodium chloride, which is a hypertonic solution, high sodium concentration, which draws water out of the swollen cells, making it particularly useful for reducing cerebral edema. We also see it used for things like fluid overload, pulmonary edema, and worsening heart failure, but those patients are really closely monitored. And whenever we're administering IV fluids, we're going to continually assess whether the patient is responding appropriately to the intervention that we are trying to utilize. So now that we've discussed vascular access devices and IV fluids, let's talk a little bit about our role as nurses before even starting IV therapy. So before you connect any IV fluid or medications, there's several safety checks that we're performing. So first, we're always verifying the provider's order. We're confirming that this is the correct patient, correct IV fluid or medication, the correct concentration and dose, the infusion rate, route, and duration of therapy. So I'll always ask, does this order make clinical sense for my patient? Then we're assessing our patient. We're performing a patient assessment before initiating therapy. This includes vital signs, hydration status, lung sounds. Do they have any edema, any heart and kidney function issues? Are we looking at current lab values, especially electrolytes and renal function? And then any existing vascular access and vein quality. We're also checking and verifying allergies before administering any IV medications and compatibility. If medications are being infused through the same IV line, we're determining whether they're actually compatible. Some medications cannot be mixed because they form precipitates or become ineffective. They can also cause catheter occlusion, so we're always consulting with our institution's compatibility resources. And then before beginning, we're making sure that we have everything we need. We're gathering our equipment. This includes appropriate vascular access device, IV solution or medication, our primary tubing, extension tubing if we need it, any alcohol or chlorhexidine swabs, flushes, transparent dressing, an infusion pump, gloves, and other necessary supplies. This is going to reduce any breaks in aseptic technique, and it's going to improve our efficiency. And then finally, don't forget patient education. We're explaining why the IV is being started, what the patient should expect during insertion, the purpose of the IV therapy, any signs that they should report immediately, and we want to teach our patients to notice if they are experiencing any pain, burning, swelling, any leakage, numbness, coolness around the IV site, because many complications are first noticed by the patient, so encouraging them to speak up is going to improve safety. So once IV therapy has been initiated, our responsibility isn't going to stop there. One of the most important roles is the ongoing assessment. That ensures the therapy remains safe and effective. So every time you enter the patient's room, the IV should be part of your assessment, starting by assessing the IV insertion site, inspecting and palpating for any redness, swelling, warmth, any coolness, drainage, leakage, or bruising, and tenderness. We want to ask the patient if they have any discomfort because that is not normal. Next, we're assessing the dressing, which should be clean, dry, intact, and transparent. We should be able to visualize the insertion site through the dressing. If it's loose, wet, bloody, or lifting, it should be changed using sterile technique according to your facility's policy. And then patency, we're always assessing the catheter for patency. The IV should be able to flush easily without any resistance. If we do meet resistance, we might want to stop that immediately. We're never forcing the flush. We want to assess for any kinked catheters, maybe a closed clamp or catheter occlusion. If we do try to force the flush, it could damage the catheter or even dislodge a clot. So that's not something we want to do. And then remember, we're checking for blood return on our central lines. So verifying blood return according to your institution's policy before administering any medications, especially vesicants and chemotherapy, because blood return is going to help us confirm that the catheter remains within the vein. Keep in mind that absence of blood return doesn't always mean that the catheter is unusable, but it really does require further assessment before administering medications. And then always verifying that the IV infusion rate is correct. That is the prescribed rate. I'm short-circuiting a little bit with my voice. But yeah, we want to ask ourselves, is the correct fluid hanging? Is the correct rate programmed? Is the patient receiving too much or even too little fluid? Pump settings, we want to never assume that the pump is correct because someone else programmed it earlier. We should verify that independently by making sure this is the correct patient, correct medication, correct concentration, rate, and volume. Also paying attention to pump alarms. They're telling you something needs to be assessed, so don't just simply silence those. And then pain assessment, we're always asking our patients about pain. Does the IV hurt? Does it feel like it's burning? Do you feel any different than before? Noticing any infiltration or phlebitis. Then let's talk about documentation. So if it wasn't documented, it wasn't done. So accurate documentation is going to be essential, and that's for communication among the healthcare team, continuity of care, patient safety, and our legal protection. So whenever you initiate or assess an IV, there are several key pieces of information you should document. First, the anatomical location of the IV, so be specific as possible. Is this in the left forearm or the right hand, right upper arm? And then for central lines, we're also documenting the type of catheter and insertion site, such as the right internal jugular central line or left upper arm pick. Next, we're documenting the catheter gauge, and this is going to communicate what therapies the IV can safely support. And then the dressing, we're documenting the condition of that. It's clean, dry, and intact, or if it was changed, we want to know the date and time, why it was changed, that sterile technique was used, and how the patient tolerated that procedure. And then assessment findings, routine IV assessments should also be documented. So things like site without redness, swelling, drainage, or tenderness, that the dressing is intact, the IV is flushing easily, or the infusion is running at the prescribed rate, that blood return is present, and that's when appropriate, if they have a central line. No signs of infiltration or phlebitis. If there is a complication, we are documenting exactly what we observed. And then finally, we're documenting how the patient tolerated both the IV insertion and the ongoing therapy. So this slide is talking about the most common local complications of IV therapy. And so here, early recognition is going to be essential because many of these complications can be reversed if they are identified quickly. So every time we assess our IVs, we're looking for these problems before they become severe. So we have infiltration, which occurs when a non-vesicant fluid leaks out of the vein into the surrounding tissue because the catheter is no longer fully inside the vein. So remember that infiltration is non-vesicant fluid outside of the vein. So things you'll notice: cool skin, swelling, pallor or even blanching, tightness, slowed or stopped infusion, and the patient may report discomfort or a feeling of fullness. Our first action is going to be to stop the infusion immediately, remove the IV catheter, elevate the extremity, apply a warm or cold compress according to the type of solution and your facility's policy. We can restart the IV in another extremity if continued therapy is needed, and we're documenting our findings. Extravasation, this looks similar to infiltration, but it's much more serious, and this is the one that occurs when a vesicant medication leaks into the surrounding tissue. So things like chemotherapy, vasopressors, some antibiotics, calcium chloride, hypertonic solutions. Because these medications can actually cause tissue necrosis, extravasation is considered a medical emergency. So we're looking for things like pain or burning, swelling, redness, blistering, any skin discoloration, delayed tissue damage. Patients will often tell you that it burns. We're never ignoring that complaint. So nursing interventions, we should stop the infusion immediately, but with this one, we want to leave the catheter in place. And we want to attempt to aspirate any remaining medication from the catheter. We're notifying the provider, and we might be able to administer an appropriate antidote if that is ordered. We're elevating the extremity. We're applying a warm or cool compress, again, depending on the medication and your institution's policy. We're documenting that carefully, and we're monitoring it very closely. Next is phlebitis, which simply means inflammation of the vein. This is usually caused by a mechanical irritation from the catheter. It can also be a chemical irritation from medications or an occasional infection. So we're looking for any redness that is following the vein, warmth, pain or tenderness, swelling, and sometimes we can feel a palpable cord within the vein. We want to stop the infusion, remove the catheter, apply a warm compress, elevate the extremity. We can restart the IV in another location, and we're documenting and continuing to monitor. Thrombophlebitis, this is essentially phlebitis plus a blood clot. So in other words, the vein is inflamed and now it contains a thrombus. So you will often see things like significant redness, warmth, swelling, a firm palpable cord, pain along the vein, and occasionally a low-grade fever. Patients will often report increasing tenderness that extends beyond the insertion site, and so treatment would include stopping the infusion, removing the IV, applying a warm compress, elevating the extremity, and notifying the provider. Some patients may also require anticoagulants depending on the severity. The presence of a clot makes this more serious than just simple phlebitis. Finally, we have a hematoma. This occurs when blood leaks out of the vessel and collects in surrounding tissue. It's most commonly caused by a difficult IV insertion, vein puncture, catheter removal without adequate pressure. So you'll often notice things like bruising, swelling, tenderness, and discoloration. And the treatment, we're going to stop the infusion. If it's still running, we're going to remove the catheter, apply firm pressure until the bleeding stops, and apply a cool compress during the first 24 hours to reduce bleeding and swelling. And then after the first 24 hours, we can apply a warm compress that helps reabsorb the blood. And we can also elevate the extremity. So we've just discussed local complications, which occur at or around the IV insertion site, and now we're kind of shifting our focus to systemic complications. So problems that affect the entire body and can quickly become life-threatening if not recognized early. So although these complications are less common, they require immediate nursing intervention. Things like fluid overload. The most common systemic complication you'll encounter from enteral therapy is fluid overload, which occurs when fluids are infused faster than the patient's heart, kidneys, or circulatory system can even handle. And patients at highest risk include older adults, infants, patients with heart failure, patients with kidney disease, and patients receiving rapid or large volume infusions. So we're watching for things like increasing blood pressure, bounding pulses, tachycardia, jugular vein distension, peripheral edema, crackles on auscultation, shortness of breath, decreased oxygen saturation. One of the earliest signs is often crackles at the lung basis or new onset dyspnea. If we do suspect fluid overload, we're going to slow or stop the infusion, elevate the head of the bed. We're going to assess lung sounds and oxygen saturation. Definitely notify the provider. We might be administering oxygen, anticipating diuretics such as furosemide if prescribed. Again, our priority is to either slow or stop that infusion and assess our patient. Next, we have an air embolism, which occurs when air enters the vascular system and then travels to the heart or lungs. This is uncommon, but it is a true emergency, and it's often associated with central venous catheters, especially if the tubing becomes disconnected or the catheter is open to air. So, assessment findings: patients may suddenly develop sudden dyspnea, chest pain, tachycardia, hypotension, anxiety, and cyanosis. Nursing interventions: we're going to immediately clamp the catheter if that's appropriate, place the patient in the left lateral Trendelenburg position, which helps trap the air in the right side of the heart, and it reduces movement into the pulmonary circulation. We want to administer oxygen and notify the provider, or just even have an rapid response team activation. And of course, monitor our vital signs really closely. But with this, prevention is key. We're always ensuring that the tubing connections are secure. We're removing air from the IV tubing before administration. We're clamping central lines when changing tubing or caps. Then we have central line associated bloodstream infection, also known as eclampsia, which is a bloodstream infection that develops in a patient with a central venous catheter. And because central lines provide direct access to the bloodstream, preventing infection is one of our highest priorities. You'll hear about it a lot in the hospital. So our assessment findings: we're monitoring for fever, chills, any redness or draining at the insertion site, an elevated white blood cell count, hypotension, and tachycardia. The best treatment is prevention here. So helping to prevent eclampsias by performing meticulous hand hygiene, using sterile technique during dressing changes, scrubbing that hub before every access, and maintaining a clean, dry, intact dressing, and then removing central lines as soon as they are no longer needed. Then we have septicemia, also known as sepsis. This is a bloodstream infection that progresses. It can be life-threatening. We want to watch for fever, hypothermia, tachycardia, tachypnea, hypotension, any altered mental status, an elevated lactate, decreased urine output. This is an emergency, so we're following our facility sepsis protocol and we're notifying the provider immediately. We're obtaining blood cultures if ordered, probably going to start broad spectrum antibiotics, administering IV fluids as ordered, and monitoring for signs of septic shock. And then a catheter embolism. This occurs when a portion of the catheter breaks off and migrates through the bloodstream. Although this is also rare, it can occur if excessive force is used during catheter removal or if the catheter becomes damaged. So depending on where the catheter fragment travels, patients may experience chest pain, arrhythmias, palpitations, dyspnea, and sudden cardiovascular instability. So if a catheter appears damaged or shortened after removal, we're saving that catheter. We're notifying the provider immediately. We're not discarding the catheter. We're monitoring the patient really closely. The patient may require some imaging and the retrieval of that catheter fragment by interventional radiology or even surgery. So for complications, when should you stop the infusion? So we don't automatically stop an infusion every time something seems wrong. We're going to first assess the patient and the IV site. There are several findings that should immediately make you pause the infusion and investigate. Things like a swollen arm. So if you notice swelling around the IV site or the entire extremity, we're going to stop that immediately. A red streak following the vein, that suggests phlebitis or thrombophlebitis. This means the vein has become inflamed. We also want to stop the infusion, assess the patient, and discontinue the IV if that's indicated. A cool, pale extremity. This is a classic sign of infiltration. The catheter is no longer in the vein, so the fluid is leaking into the surrounding tissue. So we want to stop that infusion immediately. Blood backing up. If you notice blood backing up into the IV tubing, we can't ignore that. We're going to first assess the situation. The IV pump may be stopped, the tubing may be clamped or kinked, the catheter might be occluded, or the IV bag may be empty. So we want to pause the infusion here while we troubleshoot the problem. The pump alarming, this is one of the biggest mistakes new nurses make, is assuming that the pump is the problem. The pump alarm is a symptom, not the problem. So always assessing the patient first. Some common reasons for alarms include occlusion, infiltration, air in the tubing, an empty IV bag, kinked tubing, closed clamp, or low battery. So don't just silence the alarm and walk away. We're going to assess the patient, assess the IV site, check the tubing, check the pump settings, correct the underlying problem before restarting the infusion. Sometimes if you troubleshooted all of that, you need to just change the pump. Finally, let's discuss when it's appropriate to discontinue IV therapy. So although starting an IV is an important skill, knowing when to remove it is just as important. So the goal is to keep an IV only as long as it's clinically necessary. The longer a catheter remains in place, the greater the risk for complications, again, such as infection and phlebitis. So the most obvious reason to remove an IV is when the prescribed therapy has been completed. So like the patient has finished their full course of IV antibiotics, or the IV fluids are no longer needed. If the patient has had a complication, we're removing the IV. Things like infiltration, phlebitis, thrombophlebitis, hematoma, things we've just talked about. If there are any signs of infection at the insertion site, we are removing the IV. So things like redness, swelling, warmth, perioral drainage, increased tenderness. An IV has occluded, should be discontinued if it becomes occluded. And we cannot restore that patency. We're going to take that out and start a new access if that is continued to be indicated. Current best practice is to remove peripheral IVs when they are no longer clinically indicated. So rather than replacing them every few days, we're reducing any unnecessary procedures, and we're lowering the patient's risk of infection and discomfort. So as soon as we should always be asking ourselves each shift, does this patient still need an IV? If the answer is no, we're going to discuss continuing that with the healthcare team if it hasn't already been addressed. And so when removing a peripheral IV, we're stopping the infusion and disconnecting the tubing. Then we're removing the dressing carefully, we're stabilizing the skin and withdrawing the catheter slowly and smoothly. We're applying gentle pressure with a sterile gauze until the bleeding stops. We're inspecting the catheter, and that's to ensure that it's completely intact. We're applying a clean dressing or a bandage and documenting the removal, including the condition of the site and that the catheter tip was intact. We never want to discard the catheter until you've confirmed that it's intact. So if any portion appears to be missing, we're notifying the provider immediately, because catheter embolization, it's rare, but it's very serious. And that is it for today. I hope you enjoyed. I guess I didn't add the reference here, so I will to the PowerPoint itself. Hope you have a good day. Thanks for listening.